Thank you. Bismillah. Assalamu alaikum. Hayakum Allah jami'an. First of all, it's my pleasure to be with you today to talk about some aspects of ITP pathogenesis and some diagnostic aspects as well. And I will shed light on some aspects even of novel agents of ITP management, as it relies mainly on deep understanding of ITP pathogenesis. And I would like also to thank Dr. Muhammad Al-Muhammadi for such a wonderful organization for this conference, and I hope that you enjoy my lecture. This is the most important issue to me, by the way. So basically, ITP is an acquired immune destructive thrombocytopenia characterized by isolated thrombocytopenia. By definition, it has to be less than 100,000 platelet. And the mechanism of action, the mechanism of pathogenesis of ITP mainly comes from pathogenic antiplatelet autoantibody and decreased platelet production, insufficient platelet production from megakaryocytes. And recently, we start to recognize the role of cytotoxic T cells in platelet destruction. As autoimmune disease, it has more female predominance, as you know, and ITP is manifested with bleeding tendency, easy bruising, purpura, petechiae. Serious bleeding might occur, especially if there is severe thrombocytopenia. The classification of ITP, usually it can be classified according to clinical schemes or etiological schemes. A newly diagnosed patient, usually he will be labeled as acute thrombocytopenia, acute ITP, if the time lapsed is less than 3 months. If he will have persistent ITP if he's not responding to ITP management within 3 to 12 months. He will be labeled as refractory ITP patient if the time lapse is more than one year, and the patient will be labeled as severe ITP if there is any bleeding manifestation, whatever stage he is on. Etiological classification, which is actually I'm concerned about it as pathologist, as primary or secondary. And primary ITP, which represent about 80% of ITP patient, in which isolated thrombocytopenia is not associated with another disorder. It is usually a diagnosis of exclusion and no pathognomonic clinical or lab feature. And the best diagnostic approach is the response to steroid, IVIG, or one of the novel agents. Secondary ITP or immune thrombocytopenia, it encompasses all other immune-mediated thrombocytopenia associated with infection, associated with autoimmune disorder like SLE, like Evans syndrome, and more commonly nowadays associated with lymphoproliferative disorder like CLL and to some extent some lymphomas. As I said, ITP, primary ITP represent about 80% of the patients has been diagnosed with ITP according to many studies, and secondary ITP represent about 20%, of which SLE and CLL represent the most type of ITP. Now, pathophysiology of ITP is quite complex because actually it encompasses almost all the immune system subsystem. It includes also T cells, B cells as part of adaptive immune system, but also it activates an innate immune system represented by macrophages, sometimes monocyte, and natural killer cells. And it's a complex immune dysregulation, but the main issue here is development of autoantibody against platelet surface glycoproteins, mainly glycoprotein 2B3A for fibrinogen, and glycoprotein 1B9 for phonoylbrand. But this does not mean the antibody is only exclusive for those glycoprotein. It might include thrombopoietin receptor. It might include also collagen receptor. And the initial spark of pathogenesis of ITP started from loss of function of Treg cells. Treg cells are specialized T cells responsible about suppression of immune response, mainly suppression of T follicular helper cells, T follicular helper cells. So loss of function of Treg cells will lead to activation of T helper 1 and down-regulation of T helper 2 and production of autoreactive antibody production, which will lead to platelet opsonization, opsonizing the platelet glycoproteins 2B3A and glycoprotein 1B9, leading to phagocytosis by macrophage through FC receptor. Again, opsonized platelet will be phagocytes through spleen macrophages mainly, but also in liver it might happen in copper cells in the liver, and the phagocytosis will be mediated through FC and Syk receptor, and no wonder that some novel agent will target this mechanism. So phagocytosis through this mechanism, it will lead to destruction of a platelet, splenic macrophages destruction of UFC and Syk receptor, and also direct platelet lysis via complement. So complement activation, especially at acute and refractory ITP, might occur also through the complement. And actually, this is affect us even in lab diagnosis, as we will see with MEBA assay later on. And even if you see the bone marrow of patient ITP, you will see many megakaryocytes, and you assume that those megakaryocytes are producing, but in fact, there is also there's impaired of platelet production of megakaryocytes, because also impaired of thrombopoietin production and increase of para-apoptotic activity and increase of apoptosis of those megakaryocytes, because the antibody, it attack the demarcation membrane in which the platelets spuds off from the megakaryocytes. This highlights the platelet glycoprotein and platelet structure as a whole. And if you see, the main antibody is targeting the fibrinogen receptor, and fibrinogen receptor is very crucial for platelet integration and also for von Willebrand. And von Willebrand antigen is responsible as platelet activation at high share rate, which is the initial phase of platelet activation, as you know. But also about 3 to 4% of antibody might be directed against collagen, and some of platelet autoantibody might be directed also to thrombopoietin receptor. Thrombopoietin is the key growth factor in platelet production, megakaryocyte specialization and differentiation, and many studies actually prove that there is insufficient production of thrombopoietin in patients with ITP patient. Look at this study, which has been published in 2009 by David et al. And he compared actually between normal patient versus aplastic anemia with severe thrombocytopenia and ITP patient also with severe thrombocytopenia. And look at the level of thrombopoietin. Here it is within low level because the patient has normal platelet. In aplastic anemia, there is low platelet but high increment of thrombopoietin to increase the platelet production, while here it is almost normal, reflecting the impaired of TBO production in ITP patient, which became the rationale for using TBO mimickers and TBO agonists like romublastium and eltrombopag, as you know. This is one of the hero actually in our field, Harrington, because he sacrificed himself and he injected himself to confirm the hypothesis about presence of antiplatelet antibody. And he was taken by experiment of COMS when he detected that for autoimmune hemolytic anemia, and he injected himself with half liter of ITP patient plasma, and after 3 hours he developed severe and life-threatening thrombocytopenia. And also he had having a headache and seizure, and the thrombocytopenia lasted for 5 days, and then he fully recovered. And then he take his team one by one, and he sacrificed with his student and his nurses also, and all of them showed thrombocytopenia, and then he confirmed the hypothesis of presence of antibody platelet. As long as they agree, that's fine, and they have. I think we should do it for our students, huh? And 20 years later, now he did it actually in 1951. I was not born at that time, so I don't know if there is IRB approval at that time or not. In 1980, many studies proved that those antibody is IgG mainly or IgM to lesser extent, and those IgG and IgM is directed mainly toward glycoprotein 2b3a and glycoprotein 1,5b. The role of Treg cells, T regulatory cells, and Treg actually is subspecialized cells, T cells. Usually it is responsible of maintaining immune tolerance, and usually it down-regulate T follicular helper cells on the spleen and in the lymph node. And you know, T follicular helper cells from which T cell angiomoblastic T cell lymphoma originate. Nishimoto, in order to prove that the role of Treg cells in ITB, he depleted mice from Treg cells in phase 1, and 40% of Treg deficient mice became thrombocytopenic and displayed also IgG antiplatelet antibody. In phase 2, he back transferred the purified TIG into the mice and prevented thrombocytopenia, confirming the role of Treg in ITB, which became actually one of the best study as the cornerstone in using of some novel agents to target, to restore the Treg function in ITB, and I will show it to you recently. And I see this complex slide, but actually, if you see, actually this slide summarizes the mechanism of action of the novel agents. Almost all the novel agents until 2022, some of them has been approved, some of them still are as molecule and or phase 1 or phase 2 trial, but this slide summarizes the mechanism of action of the majority of those novel agents. And as I said before, it relies mainly on deep understanding of pathogenesis of ITB. And each of those novel agents are targeting a specific site for ITB pathogenesis. If you see Sec inhibitor like fostamatinib, which has been approved by FDA recently, it targets the Sec receptor, which is tyrosine kinase inhibitor downstream after FC receptor and responsible of a signal transduction pathway to activate the macrophage for phagocytosis. Proton tyrosine kinase inhibitor has the same mechanism of action, and no wonder that some molecules will target Treg to activate and to restore their function, including some molecules like anti-CD 154 and anti-CD 40, which are responsible of maintaining the action of T follicular helper cells over autoreactive B cells, which will lead to differentiation of those autoreactive B cells to plasma cells during class switching and somatic hypermutation and germinal center. Also, targeting those plasma cells with monoclonal antibody became one of the novel agents like bortezomib, daratumumab anti-CD38, and also anti-CD19 to target the B cells. FC neonatal blockers to target the antiplatelet antibody directly to prevent them and to increase the clearance of those antibody from the patient plasma and patient sera has been used. Still, those are molecules in phase 2 study, and you can appreciate the broad action of steroid here, because the steroid also affecting the macrophages, affecting the autoreactive B cells, and also it has a role here in restoring the function of Treg, and also it has a role of antiplatelet antibody, and also to improve the production of megakaryocyte, platelet from megakaryocyte. And this is why it is the first line treatment of ITP with about 80% response in ITP patient. Insufficient platelet production from bone marrow, from megakaryocytes by antibody against the demarcation membrane of the megakaryocytes, and this is why we are using TBO mimickers and TBO agonist. This is just to highlight the role of fostamatinib, which is a second inhibitor in B lymphocytes and in macrophages as well as compared with TBO mimetics like electrombobag and romoblastin. And the role of rituximab also has been used, has been tried also in severe and refractory ITP patient. Splenectomy, yes, still it's old, but in some cases it might be gold as clearing of the anatomical space in which the phagocytosis happen. Now, this is just to summarize the mechanism of action of those inhibitors. If you see second inhibitor like fostamatinib, it decreases the platelet destruction by inhibition of macrophage phagocytosis, and proton tyrosine kinase inhibitor has the same also, because they target the same mechanism. FC are neonatal blockers also, like rozanolizumab. I cannot pronounce the majority of the names actually. It increases antiplatelet antibody clearance and decreasing the peripheral platelet destruction, and also it maintains and reduces the immune response against megakaryocytes. And if you see now, the steroids actually has broad action of immune cells over the macrophages, T and B cells. And if you see B cell depleted therapy like anti-CD20 or rituximab, it has also the ability to restore the T cell tolerance, which is the Treg function. And as I said, it's the initial spark of ITP pathogenesis. Plasma cells targeting therapy like proteasome inhibitor, pertuzumab, and daratumumab also decrease in short and long-lived plasma cells, thus decreasing antiplatelet production. B cells and plasma cell targeting therapy decrease the short and long-lived plasma cells the same actually. And T cell targeting therapy like anti-CD154 and many other molecules to restore the function of Treg cells. So actually it was the first part of my lecture. So and I will go now to some slides in diagnosis of ITP. As I said before, ITP actually autoimmune hemolytic anemia has been taken as a prototype for ITP diagnosis, because because of the similarity between the two diseases. If you see in autoimmune hemolytic anemia, we have autoantibody related hemolysis and we have autoantibody related destruction. And the biomarkers, even we have clear and well-defined biomarkers in autoimmune hemolytic anemia. Hemolysis biomarkers like high LDH, red X, bilirubin, reduction of haptoglobulin. And also here we have platelet biomarkers, but it is not clear as what we have here in autoimmune hemolytic anemia. We have platelet count, MBV, which is usually increased, platelet distribution width, which is similar to RDW in iron deficiency anemia. Usually it will be high because of anisocytosis between young and old platelet, and reticulated platelet and immature platelet fraction, which is a new indices which has been adopted, and now it has been fixed now in new machine, and it has to be utilized in diagnosis of ITP. But the problem actually is, here we have a pathognomonic test for autoimmune hemolytic anemia, and still we have here a gold standard, which is MEBA assay, monoclonal antigen embolization of platelet antigen. But the problem comes from lack of proper sensitivity in MEBA assay, because actually we have high specificity, because MEBA assay target glycoprotein 2B3A, and it target glycoprotein 59 Fonwell-Brand glycoprotein, and the majority of autoantibody is directed against those antigen. But when it comes to the sensitivity, we have low sensitivity because, as I said before, we have complex immune dysregulation, we have complement, we have Treg cytotoxic T cells, and this is why still we don't have a highly sensitive assay. Diagnostic workup of ITP includes CBC, reticulocyte to rule out possibility of EFAN syndrome, blood film to check if there is any especially CLL or any lymphoma. HIV, hepatitis B, especially before rituximab. H. pylori, because it has been historically connected with ITP, and in many occasions they try to treat H. pylori in order to treat some refractory patient with ITP. Quantitative immunoglobulins for IgM, IgG, IgA, and that autoimmune workup also has to be done. Bone marrow, especially if the patient is more than 60 years, or if he has abnormal findings, or before splenectomy. Blood group RH, if considering anti-D, which is old therapeutic approach, and further test according to the situation. A clinical presentation, usually patient will present with petechiae and some bruises, and if you see the CBC, you will find isolated thrombocytopenia if you are talking about primary ITP. And main platelet volume is high because we have giant platelet and small platelet, and platelet distribution width is high because we have anisocytosis between the platelet. And neutrophils and RBCs are normal here. This is one of the most interesting cases that I ever encountered. I think one of my residents, they know the case. Actually, we received 10 years old referred from Aljabry Hospital as a known case of refractory ITP, failure of first line, but he was bleeding while platelet count is more than 70. And on examination, he has mild splenomegaly. And they referred him to King Fahd Medical City for further management because he's bleeding while high platelet count. When we do the CBC, we discover that he has mild MCV, MCH, and mild anemia. He's iron deficient anemia because of recurrent bleeding, as you know, and platelet is high, MBV is high, BDW, platelet distribution width, was normal, and this is his preferred. So what do you think? BFA 100 was not done, aggregation study was normal. This is platelet, by the way.
No, great.
Yeah, actually, they did a bone marrow before they consult us, actually, because they want to proceed doing splenoectomy. So we receive also bone marrow, and the bone marrow was mildly hypercellular, and it was fibrosed. So grade 2 out of 4, or it might be also 2 out of 3. So actually, he was having gray platelet syndrome, and when we do electron microscopy, this is alpha granules in normal patient, and this is deficiency, almost deficient with all alpha granules, which is the most abundant granules in the platelet, as you know. So we requested for Nabil 2 gene, and it came to be positive. Okay, reticulated platelet. Reticulated, you can see here a normal patient. This is the platelet, and this is immature platelet, or immature, it is reticulocyte, reticulated platelet. But in ITP patient, if there is severe thrombocytopenia, the IRF is high. So reticulated platelets, immature, newly released platelets, which are more reactive and contain more RNA and can be counted using flow cytometry or fully automated analyzer. Immature platelet fraction is an automatic method to detect a reticulated platelet. And some study actually prove the utility of IRF in diagnosis of ITP patient. And the cutoff value of immature reticulated factor at 9.5 could be diagnostic for ITP with high sensitivity, actually 88, and high specificity. And now it has to be one of the indices in which you choose your new machine, especially if you are planning to have sophisticated machine in order to help you to diagnose a patient with ITP and if in digital pathology methodology. Serological test, there are many direct measurement way of platelet bound antigen, like ELISA assay, but the problem is that we have a variety of technique available, complex and labor intensive, huge variability of results, and it does not differentiate between pathological and non-pathological antibody. It counts the total antibody in the patient's sera, and also the bound platelet, and also from the elute of platelet. If you can see here, this is the normal, and this is the cutoff, but still there are many platelet antibody in this patient. In immune and non-immune, still we can see some antibody in the patient serum, and but those are non-pathological antibody. This is why the monoclonal assay or MEBA assay is the gold standard for qualitative technique for platelet antibody identification. It can be done like that with in vivo and in vitro antibody, direct or indirect, to detect also the alloimmune thrombocytopenia, like neonatal alloimmune thrombocytopenia. And also it can be modified to detect the autoantibody against glycoprotein 2B3A with high specificity, because it targets the glycoprotein 2B3A. But the main issue here is the low sensitivity of those assays, because autoantibody against thrombopoietin and also CMPL, and low titer or sequestration of antibody, which can be seen also in that negative autoimmune hemolytic anemia, but it has higher percentage in ITP. The antibody will be eluted easily and will be lost easily from the platelet surface. And also autoantibody independent mechanism, like cytotoxic T cells. There are many studies to improve the sensitivity of MEBA assay. Still, it is in the way for diagnosis of ITP. Now, just to conclude, I hope that I did not exceed the time. ITP is the clinical expression of variety of thrombocytopenic disorder with different underlying mechanisms. So it is ITP syndrome better than ITP as isolated thrombocytopenia when you come at the pathogenesis level. The role of Treg cells has to be explored further as primary event, not a minor contributor. ITP remains diagnosis of exclusion. And the ideal test for ITP has yet to be developed, as current test method need to be improved, especially at the term of sensitivity and response to therapy, steroid, IVIG, or one of the novel agent as the best diagnostic parameter. Platelet autoantibody testing has a high specificity but low sensitivity. New platelet indices has to be integrated with other parameters. And thank you.